The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, and welcome to this new webinar organized by the Maternal Health Supplies Caucus of the Reproductive Health Supplies Coalition and the TXA Workstream. You are all muted in order to prevent background noise. This webinar is being recorded, and a link to the audio and video will be sent to all members of the caucus and all participants in a couple days. We will not open the microphone, but you are most welcome to please write your questions in the questions box at the right-hand side of your screen. Without further ado, let me introduce our moderator and the chair of the Tranexamic Acid Workstream, Dr. Metin Gulmesoglu. He's the CEO of the Concept Foundation. Metin, the microphone's yours.
Thank you, Milka, and good morning, good afternoon, colleagues and friends. We thought about this webinar as a way of communicating the increasingly accumulated knowledge about tranexamic acid use for postpartum hemorrhage to a broader audience. We have a tranexamic acid workstream within the caucus, and our experience is every time we meet, we feel that there is no systematic pickup of tranexamic acid use, and there is always questions about the evidence, about the recommendations, about availability. So we planned this webinar to update everyone about these issues. We have three famous, well-known speakers. The first one is Halima Shakur Still. She's a professor of clinical trials from London School of Hygiene. And Halima has been one of the key individuals who actually generated most evidence on tranexamic acid in general, but also in particular for postpartum hemorrhage use. We will then have Mariana Whitmer from WHO, and she's been the key person updating and issuing the recommendations from WHO on this topic. And then the third speaker is Andrew Story from CHAI, who has been collecting all the information about different aspects of the TXA market and market supplies and access throughout the world. So we are looking forward to an excellent set of presentations. The presentations will be around 10 to 15 minutes long, and you are most welcome to put the questions in the chat, and we will try to respond to them at the end of each presentation. But if we have time, we will come back to them later on as well. We have 1 minute for this webinar, and we hope to finish it on time. So without further delay, I want to give the floor to Halima to present us the latest evidence and science and practice for TXA. Thank you. Halima, over to you.
Thank you very much, Metin, and good afternoon, good morning, everyone. It's really wonderful to have the opportunity to talk about the science of tranexamic acid. And today, I hope I can impart to you some of the, sorry, next slide. How does tranexamic acid reduce bleeding, and to present some of the evidence for tranexamic acid as a treatment for postpartum hemorrhage, and discuss if there's a role for TXA in preventing PPH, and what gaps do we have in our knowledge which limit the use of TXA. Tranexamic acid, or TXA as it's known, is a story of of missed opportunities. It was invented way back in 1962, so over 50 years ago, even coming on to 60 years ago. And the initial development of tranexamic acid was for it to be used as a treatment for postpartum hemorrhage. Utako and Shusuke Okamoto, who were working in post-war Japan, at a time when Japan was a relatively poor country and maternal mortality was quite high, Utako especially really wanted tranexamic acid she wanted to actually find a treatment for postpartum hemorrhage and invented tranexamic acid. However, she wasn't able to do that because she wasn't able to convince obstetricians to do the trials that were necessary. Next slide. So why did they get interested in tranexamic acid? Utako and her husband observed something that as clinicians, all the clinicians would know. If you take a blood sample, it will initially clot, and after some time, it will break down. And this particular observation led them to start studying clotting and bleeding. So what happens when we injure ourselves or when there's injury to our blood vessels? We form a clot, and integral to that clot is something called fibrin. Fibrin is needed to stabilize the clot. Next slide. However, sorry, if you could, lovely, thank you. However, when we're forming a clot, we have a sort of a normal process ongoing that's happening as we sit here. We have a substance called plasminogen, which is circulating in our bodies all the time. If we injure a blood vessel, you release something called plasminogen activator, and TPA, tissue plasminogen activator, is one of the most commonly known, and it's the one that's involved in clot breakdown or fibrinolysis. So you get TPA binding to plasminogen, and it becomes plasmin, and plasmin will bind to the fibrin. That's the yellow strand that holds the clot together and breaks down the blood clot. And this is the fibrin degradation product, includes things like D-dimer, etc. Tranexamic acid works by blocking the plasmin binding to fibrin that stops the breakdown of fibrin. And as we're bleeding, we really do not want a clot to be broken down. However, normally, as we're bleeding, you have the clot making and the clot breaking processes ongoing. So whether this is a good or bad thing in hemorrhaging is debatable. Next slide. Tranexamic acid was originally just marketed for use in mild bleeding conditions because, as I said earlier, the Okamotos were unable to convince clinicians to do the necessary randomized controlled trials that would have looked at tranexamic acid as a treatment for postpartum hemorrhage. So they sold on tranexamic acid to a commercial company, and it was never developed any further. However, clinicians, especially surgeons, started doing lots of small trials, especially in surgical bleeding. And we did a systematic review way back in 2012, and there was already 95 trials, and there's a lot more since, that shows that tranexamic acid can reduce the need for blood transfusion by about a third in surgery, and it can reduce mortality as well in surgery. So this is usually major surgery like cardiac surgery, orthopedic surgery, etc. Next slide. On the basis of the surgical information that we saw, and the fact that it could reduce mortality and reduce bleeding, we wondered whether tranexamic acid could reduce bleeding in trauma. And we started the CRASH-2 trial. After all, surgery is just a surgeon cutting you with a clean scalpel versus being stabbed by a dirty knife in the back streets of Bogota or somewhere like that. We felt that the bleeding would be no different. So we conducted a large trial in trauma patients. Next slide. And we showed that tranexamic acid could reduce the risk of trauma patients bleeding to death by overall by about 15%. And when you're stabilizing blood clots, you worry, when you stabilize bleeding, you worry about blood clotting. And there's things like deep vein thrombosis, pulmonary embolus, and strokes. And we saw no increase in trauma patients from these events. So it reduced bleeding to death without increasing clotting events in trauma patients. One of the things we saw was that there was a time to treatment interaction. The earlier you were treated, the better the outcome. So within the first hour of treatment, you had the best outcome. After 3 hours, there was no benefit or even harm. So treatment had to be given within 3 hours of injury. Next slide. On the basis of, while we were doing the trauma trial, these are all trauma doctors. The doctor on the left-hand side, Wale, I was in his emergency department when a woman arrived bleeding to death after childbirth. She actually died. And he was the one that asked the question, why were we looking only at tranexamic acid for trauma and not postpartum hemorrhage? Because in the UK, women don't die from postpartum hemorrhage. We thought that it was really important. We investigated this some more and learned more about this. Not surprisingly, we found the main cause of postpartum hemorrhage was, the main cause of maternal death was postpartum hemorrhage. Also, there was some really good evidence that tranexamic acid could potentially be useful because we see increased fibrinolytic activity after childbirth, that within 1 hour of childbirth, you can double your serum TPA. And there was also increased D-dimers if you had postpartum hemorrhage. And tranexamic acid has been shown to reduce D-dimer levels. So all of these offered hope that tranexamic acid could be beneficial. So on the basis of the evidence that we gathered, we designed a trial called the Woman Trial to look at whether giving tranexamic acid 1 gram as soon as postpartum hemorrhage was diagnosed, in addition to all other interventions, could reduce the risk of women bleeding to death. Over 20,000 women were with PPH were recruited in 21 countries. So this was a huge global collaboration involving nearly 200 hospitals. And amazingly, we saw identical results to those seen in trauma, that tranexamic acid reduced the risk of women bleeding to death as long as it was given within the first 3 hours of birth, of giving birth. After 3 hours, we didn't see any beneficial effect. Next slide. Again, one of the big worry about extrapolating the data from the trauma trial and why we had to do the woman trial was concern that at the time of giving birth, women are at an increased risk of thromboembolic events. And in the trial, we saw no increased risk of thromboembolic events with giving tranexamic acid. Next slide. So in summary, we saw that tranexamic acid can reduce the risk of women bleeding to death by about 1/3 if it's given within the first 3 hours. And that the other thing we saw was that it could reduce the need for urgent surgery by about 35%. And as the drug, at least in the UK, for a dose of tranexamic acid to treat postpartum hemorrhage is about £2. In some countries it's cheaper, and in some countries it's more. But it's a relatively cheap drug globally. Next slide. And we also did a cost effectiveness analysis looking at cost effectiveness in Nigeria and Pakistan, and it was shown to be highly cost effective. In the woman trial, one of the things we saw was when women died. Most women died from bleeding on the first day of giving birth. Next slide. And most deaths happened within the first 3 hours. So even if you think that the time to treatment interaction is debatable, the fact that women need to be alive to receive the treatment is really important, as death happens really early. We had the opportunity of combining the data from the woman trial and the CRASH-2 trial, so which included over 40,000 participants, to look at the effect of treatment delay. Next slide. Because one of the questions we kept being asked is, what's so magical about the 3 hour? And as you can see from this slide, that at 3 hours, there's actually no benefit whatsoever. And that the earlier you can give the treatment, the better. And in fact, if you can give the treatment immediately, you can improve survival by up to 70%. And with every 15-minute delay, you lose 10% of the benefit. And at 3 hours, there's actually no benefit. So treatment has to be really, really early. Metin and team did an amazing job of getting it into the WHO treatment guidelines within 6-7 months of the results being available. And it was put on the WHO model list of essential medicines. However, what we trialed was an IV intervention. And because many women don't actually make it to hospital, where an intravenous injection can be given, one of the recommendations was that we need to look at alternative routes. So we became interested in looking at the tablet, intramuscular, subcutaneous, and oral solution as potential alternative routes. So we've been working on a program to try and identify alternative routes. And the first thing we did was to identify what concentration of tranexamic acid we need to inhibit fibrinolysis in the blood, and then work out what would be the optimal dose and route to achieve that concentration, then test it in healthy volunteers, and then test it in postpartum women. So I can give you some information about how those are progressing. Next slide. The systematic review to look at what concentration of tranexamic acid is needed to inhibit fibrinolysis, we identified that you need between 10 to 15 milligram per liter to get substantial inhibition of fibrinolysis, but that concentrations between 5 and 10 milligram per liter would lead to partial inhibition of fibrinolysis. So that piece of work is already done. We then use data from the literature to look at sort of what levels are being achieved using a simulation and sort of modeling, and we looked at oral tablets. If you look at the y-axis of these two graphs, they're very different. One goes up only to 18 and one goes up to 80. In the oral tablets, we found that in about 1 hour, you might reach levels at the lowest level that's needed to partially inhibit fibrinolysis. However, because of the quicker stomach transit time, etc., with oral solution, it's predicted that we could reach this in about 15 minutes. So with the fastest transit time, it can be as quick as 15 minutes, but within half an hour, you could get concentrations that could fully inhibit fibrinolysis. And this is a study that was done by the team in Sri Lanka. And as you can see from this, they studied oral tablets, and this is the fast-release oral tranexamic acid. And it shows that at about 1 hour, you can reach, so it basically matched the modeling that we have, that at about 1 hour, you can reach the lowest level needed to partially inhibit fibrinolysis. And it just about, at about 2 hours, reach 10, which is a level towards full inhibition. But because we're dealing with an urgent situation, whether 2 hours is going to be quick enough for postpartum hemorrhage is debatable. Intramuscular is really promising, because the simulation and modeling, even with the slowest absorption predicted with shock, etc., we anticipate that you should exceed 15 microgram per mil in about 15 minutes. Next slide. And we have just finished a trial in trauma that shows that the IM route you can achieve within about 11 minutes levels that will fully inhibit fibrinolysis. So the intramuscular in trauma is really interesting, and it's something that can be taken forward, because we had anticipated that in shock patients absorption will be slower, but in fact it was faster, and it stayed higher longer, because in shock patients urine output is reduced, and as the drug is excreted renally, it stays higher in the blood for longer. The healthy volunteer trial looking at oral solution intramuscular versus IV has just finished recruiting, and we hope to have preliminary data by December. And on the basis of the early data that we have already finalized the protocol and the study to look at the same routes, intramuscular oral solution versus IV in pregnant women. And we hope to start this trial in about 2 weeks' time. One of the things we thought about is that as time is so critical, can we prevent postpartum hemorrhage happening in the first place, especially in high-risk women? And we're doing a large randomized controlled trial of about 10,000 women with moderate or severe anemia. And that's a Woman 2 trial. And this trial is ongoing currently in Pakistan, Nigeria, and Zambia. And we've recruited just about 2,300 women. sadly, we were affected by the COVID-19 situation. Otherwise, we would have been halfway through recruitment already. So, to sort of summarize, we've had the results from the woman trial that tranexamic acid can save lives. We've had evidence that tranexamic acid can reduce bleeding over 50 years ago. And what we don't want to happen is that what happened 50 years ago, losing the opportunity for women to benefit. And it's been 3 years since the guidelines, the WHO guidelines have been out. And at the moment, it feels as if, again, women are missing the opportunity to benefit from this knowledge. And I hope everyone that's on the webinar today can sort of feed into this system to make sure women benefit from these results. Thank you very much.
Thank you very much, Halima, for this comprehensive presentation and also indicating the direction to go in terms of new research paths. So we are running a couple of minutes late, and I will turn the floor to Mariana Widmer from WHO, and she's been leading the postpartum hemorrhage research and guideline development work in WHO for a couple of years now. And Mariana, over to you.
Thanks, Metin. So thanks for the introduction. Today I will present the WHO recommendations on tranexamic acid for Pph treatment. So let me first, next please. Thanks. Let me first start with the definition of Pph that we used for our recommendations to better understand when to administer TXA. Pph, postpartum hemorrhage, is defined as blood loss of at least 500 mL within 24 hours after birth. As we know, it is the leading cause of severe maternal morbidity and mortality. However, the majority of the Pph-associated deaths could be avoided by the use of prophylactic uterotonics during the third stage of labor to prevent Pph, and by appropriate treatment once Pph is diagnosed. So what is the appropriate treatment for a woman with Pph? Based on WHO recommendations published back in 2012, the Pph treatment consists of uterotonics, which play a central role, and oxytocin is a recommended drug, uterine massage as soon as Pph is diagnosed, IV fluid resuscitation with isotonic crystalloids and tranexamic acid. The indication for tranexamic acid has been revised in 2017, and I will now explain the differences between the recommendations in 2012 and the one updated in 2017. So in 2012, apart from recommending the use of oxytocin IV, uterine massage, and IV fluids, the use of tranexamic acid was recommended for the treatment of Pph if uterotonics failed to stop bleeding, or if the bleeding was partially due to trauma. Next, please. In 2017, in response to new evidence, mainly coming from the woman trial, WHO updated the recommendations on TXA for Pph treatment. So the 2017 recommendation supersedes the one in 2012, and it reads, any use of intravenous tranexamic acid within 3 hours of birth, in addition to standard care, is recommended for women with clinically diagnosed postpartum hemorrhage following vaginal birth or cesarean section. Next, please. When implementing this recommendation, we need to consider several points. First, that the administration of TXA should be considered as part of the standard Pph treatment package. It should be used in all cases of Pph, regardless the cause. So it is not any longer, as we said in 2012, that tranexamic acid was indicated only when bleeding did not respond to uterotonics or when the bleeding was due to trauma. So now we are saying is that the tranexamic acid has to be administered to all women with Pph. TXA is not a uterotonic. It complements the uterotonics. It is not a substitute. So women with PPH need to receive uterotonics and TXA. TXA, we have to consider, should only be available at health facilities where skilled health personnel are present because it is an injection. So which are the main resources required to use tranexamic acid? First, the health personnel needs to be trained on PPH management in general. Then we need an IV infusion set to administer TXA. And also there is need to be some sort of supervision, especially when it is first introduced. Now, if you ask about the TXA, if TXA is cost effective, and Halima already answered this, but at the time of the recommendation was done, there were no cost effectiveness analysis on TXA available. So what we did was to look at the cost effectiveness analysis used in trauma and surgery. And we extrapolated the evidence to PPH. And the evidence showed that it was cost effective. And this is what Halima already presented previously. Next, please. So regarding the administration of tranexamic acid, it is important that TXA is given as soon as possible after the birth of the baby to achieve clinical benefits. The administration beyond 3 hours does not confer any clinical benefit. TXA has to be administered at a fixed dose of 1 gram. This is 100 milligrams per milliliter IV at 1 milliliter per minute, administered over 10 minutes. If the bleeding continues after 30 minutes, or if the bleeding restarts within 24 hours of completing the first dose, a second dose of TXA of 1 gram IV is possible. Now, we have to consider that this recommendation applies only to IV use, and that tranexamic acid should be avoided in women with clear contraindication to antifibrinolytic therapy. Next, please. So finally, regarding the product characteristics, the TXA comes in ampoules. It is administered IV. It does not have any special storage conditions. It is included in the WHO EML under Medicines for Reproductive Health and Perinatal Care. This is a new indication of treatment of PPH. TXA was already in the EML for treatment of trauma, and now it also appears as indication of PPH treatment. And currently, no WHO PQ products available. However, in March 2019, WHO published an invitation to manufacturers of TXA to submit an expression of interest for product evaluation to WHO PQ team. Next. So in summary, TXA is part of the recommended package for PPH treatment. It should be used in all cases of PPH regardless its cause, and it has to be given as soon as possible after birth within 3 hours. Thank you very much.
Thank you very much, Mariana. Any questions for Mariana? I didn't see anything in the chat. I think maybe people are still waiting. Perhaps we can move on to Andrew. Andrew Story is with Clinton Health Access Initiative, and Andrew is going to talk to us about the sort of missing link between the guidelines and the patient side, bedside availability of TXA. Andrew, over to you.
Cool. Thanks, Martin. Hi, everyone. Yes, so as Martin said, I think I'm here really to darken the mood and be the pessimist somewhat, pour cold water, everything, because after those wonderful presentations from Halima and Mariana, extolling the science and the WHO's guidance on PPH, what I'm trying to do today is to talk about what's actually happening in practice, and in particular in sub-Saharan Africa, and to talk about scale up and usage of tranexamic acid for use with PPH. Like Halima said, in the UK, women aren't dying so much of PPH, postpartum hemorrhage. It is in so many of these countries in sub-Saharan Africa where these deaths are happening, where PPH is the #1 driver of maternal mortality And at the same time, the usage and availability of TXA simply isn't there. So product overview and the global guidance on the slide, I think we've largely been covered in the previous presentations. But one thing we can emphasize is this sense of governmental interest and awareness. And when CHI speaks to our partner governments, often this is coming out. And yet, you know, as I say, on the ground itself, and we'll go into some great detail, the use of TXA, where it's available, it's limited to tertiary health facilities, often teaching hospitals or the private sector perhaps. Levels of usage are irregular. And there's many parallels here, I think, with this product with other newer innovations, new products in the MNH field. So similarities here are a recurring theme, but I think in this case, TXA is an example which is particularly egregious and frustrating. And I guess if there's one thing, there's one emotion I can convey today to everyone listening, it is that one of frustration that this product still hasn't been widely scaled up in so many countries. So just move to this first slide. Earlier this year, in summer between about May and July, CHI conducted some qualitative analysis across 7 countries in Africa, trying to understand current levels of usage of TXA. And this is following some monitoring work we've been conducting for some time. We reached out to partners, mainly in the Ministry of Health and also in other stakeholders, just to better understand where the status of TXA in their country, how it's being used, and what the current plans were for extending this further forward. And there's a few recurring themes that came out when we spoke to governments in these 7 countries. These countries are Ethiopia, Lesotho, Nigeria, Malawi, Uganda, Zambia, and Zimbabwe. And we found, of course, yes, you can find examples of TXA being used for PPH in these countries, but they were always very limited, often in the private sector and often at tertiary hospitals. We found also that there was mixed news in terms of updating the guidelines. There were some examples of countries which had updated their national guidelines on use of TXA for PPH, particularly in Ethiopia and in Zimbabwe. But in most countries, that still wasn't the case. There was still work that needs to be done there. It was very rare to find TXA being included in the National Essential Medicines list, and that had great impact, great consequences in terms of the ability to procure TXA publicly. Usually, in fact, in all cases, TXA was not used in national forecasts, was not being included in quantification exercises. No budgeting was, no budgets, no funding was being put aside for TXA, and there was no major procurements, no national level procurements taking place. So to go through these line by line, country by country, to find more detail. First of all, in Ethiopia, I think Ethiopia is the country where we are seeing, quite pleasingly, still some strong momentum occurring regarding TXA introduction and rollout. And the product has been registered in the country. Guidelines and management protocols have now been developed. Some national procurement by the Ministry of Health has recently taken place, 16,000 units. And TXA is starting to be used at the hospital level across Ethiopia. There's also great interest in rolling out TXA to other levels of the health system. And implementation research, a study recently commenced in the country, looking to better understand and examine how TXA could be used, not just in hospitals, but beyond that level, health facility, health center, and maybe even the health post level in country. And I think that's something well worth watching and seeing how that develops. In Lesotho, we saw the opposite. There was no guidance on TXA usage in PPE management. Where it was used for indications of trauma, for instance, there were periodic stockouts, a basic lack of consumption data and inclusion in forecasting. Nigeria, some usage of TXA, but only at the private sector, or mainly the private sector, or in some hospitals, mainly teaching hospitals. Usage was not widely scaled up, and it was not included in essential medicines lists, nor captured in the clinical practice guidelines and protocols. In Malawi, some movement, the TXA being recently included in the ministry's must-have list of MNH commodities, and also most recently in national forecasts, and was also now being used in central hospitals. It's being used in central hospitals, but the funding situation is very significant in Malawi, as it is in all these countries, particularly Malawi perhaps, because procurement of TXA is only happening from local hospital budgets. There's no national government budget meant to fund procurement of TXA, Transamic acid, and until something changes there, it seems like procurement will not be happening. Further procurement will not be happening. In Uganda, TXA has not been included in the essential medicines list. Progress has been made, it's not there. And because of that, TXA cannot be procured by the public system. It is possible in Uganda to purchase TXA directly from a private pharmacy and then have it be used, use it in a hospital, in a public hospital. But you have to purchase it yourself. It's also available, you can find it being used for PPH in private hospitals. In Zambia, TXA has been recently included in the essential medicines list. I think that's something of a success story and a rarity across these countries that we spoke to. But still, these rollouts is limited. It's predominantly only used in teaching hospitals. And again, funding comes to the fore. The government is quite clear that they cannot scale up TXA due to a lack of funds, and as a consequence, as you can imagine, it's low levels of awareness of TXA and its utility for PPH among healthcare workers. And similarly in Zimbabwe, despite the push the government made and partners made last year to update the national guidelines to include TXA, TXA usage is still limited for use with PPH. And our sense is that previous levels of momentum have stalled. The national quantifications, national forecastings have not been updated to reflect the changing guidance, and procurement is still very limited. So we tried to take a step back and try and think about this from a supply perspective. And our first inclination is to think that supply issues for TXA don't really exist. This is, after all, a product which is a generic, which is low cost, where there's a multitude of suppliers. But when we started looking at this more, we could see bottlenecks at a supply level as well as the country level, the demands level, which I think are worth highlighting. So first, supply landscape. As we've written here, there's a broad supply base for TXA. It's a generic, large number of suppliers offering both the API and the final formulation, which on the face of it sounds fantastic. But what it also means is there's a fragmented supply. No suppliers have dominant market share. There's competition and great level of price pressure, and that means there's limited incentives for these suppliers to invest in expanding the market and increasing usage. Quality, this has been alluded to in the previous presentations. There is currently at least, no WHO pre-qualified version of TXA, although there are multiple SRA stringent regulatory authority suppliers of TXA available. And although from CHI's perspective, when we spoke to government partners, we did hear some concerns about quality, and this was highlighted in Nigeria in particular. We didn't see it as a major bottleneck at this point, but could see how it could grow to be a concern in the future. And then price. On the face of it, again, TXA is a very relatively inexpensive product. It's certainly pretty cheap to produce, and we, as it's been highlighted already, it's not so expensive to buy. We think there's we see how there's an inefficient supply chain, plenty of middlemen. The distribution has not been rationalized as such, which means there's quite a lot of markup, can be a lot of markup in supply and purchase of this product, but still nothing that's so insurmountable. But on the other hand, despite its relatively low price, it still remains relatively expensive compared to other uterotronics in most countries. And of course, there's no history and no prior budgeting for procurement of TXA, to purchase of TXA in so many countries. And finally, there's concern about decentralized purchasing. Where TXA is being purchased right now, it's often done so at both the national, the regional, and the facility level. It's very much fragmented by a purchaser base. So the large-scale procurement of TXA by national governments often remains limited. And that lack of buyer consolidation means that nationwide procurement is often inefficient and uncoordinated. And that's resulting in higher prices being paid. There's no negotiations, or it's harder to it's hard to negotiate for better deals and lower prices of products, and also planning and forecasting becomes a lot harder when you're not able to actually procure on large scale. Next slide. And then finally, I just want to highlight many of the questions that came back to us, many of the areas of investigation that came back to us as we spoke to ministry partners. So the key questions here, which we've highlighted, and really need to be worth thinking about. And what this stems from, I think, is simply a lack of anyone having to push things forward on the ground. So question number one, at what level of the health system would be most appropriate to introduce and scale up TXA? And that kind of gets to the point about the Ethiopian study that I spoke to earlier. But the lack of practical experience that's available has real world implications in terms of understanding TXA's wider utility. Put simply, there's no case study, there's no roadmap, there's no example that other countries can point to and say, hey, they've done it like this, why don't we copy that? Why don't we emulate what's been going on here? At this point, is still largely a theoretical and abstract exercise when you talk about TXA scale up in a widespread usage. The second question, how do you speed up the process to include TXA into the essential medicines list? This being such an important part, such an important step for so many countries. And what we really see is that local partners, local advocates are really required to push this process through. In Zambia, where we have seen the success, that was actually Chai who helped play this role with other partners to push this forward, to ensure that the government was really kind of focusing on TXA and adjusting, updating the EML, and also better understanding all the data that was required to do so and the implications. In Uganda, the local university there is also doing something similar, although funding is an issue there. Previously, they were funded by the EAC, and then due to COVID, those funds got redirected. We are seeing there gaps in other countries too. And then this question about funding that's come up already several times, how to ensure that sustained funding and procurement of TXA along with the inclusion of TXA into the public supply chains. And that is a reoccurring issue. As highlighted here, despite its inclusion in national forecasts, and as mentioned before, TXA is not included in Malawi's national budget for the financial year 2019, and at this point seems unlikely to be included in 2020s as well. And we can definitively say that in Ethiopia and Zambia, until the government has identified a funding source, be that within their own national funds or from a partner, until they've identified that funding source, they will not be scaling up TXA usage in the country. It's not so surprising perhaps, but that's also the theme we're hearing from other countries as well. Working out where to include that, how to include that, and advocating for their allocation of funding. And then finally, those questions about the introductory costs to normalize TXA. And we're talking here about costs, for instance, catalytic costs of funds to introduce TXA nationwide, like training and sensitizing healthcare workers, understanding how to incorporate TXA into the wider package of goods being used within MNH more broadly and to treat and combat PPH more specifically. And I think finally, if I can just highlight one key point that came up through our analysis, and that's the fact that, as I said in this final box here, despite high levels of government enthusiasm, in every country we spoke to, in all 7 African countries that we engaged with, we couldn't find any example of a strategic plan or a national guide framework to guide the introduction and scale up of TXA. Put simply, there are no plans in place. There's enthusiasm, there's support, there's great interest, but no one has actually sat down and said, here's a roadmap to scale up TXA to ensure it's being widely used in my country. And there's no examples of that, which other countries can point to as well. And that lack of a plan, that lack of a guide, I feel is one of the greatest, if not the most significant barriers towards TXA scale up across so many countries where it's needed. Let me end there. Thank you very much.
Andrew, thank you very much. And you probably could have replaced TXA with magnesium sulfate, and it would have sounded very similar as well. And I think, you used the word fragmentation a couple of times in your presentation. And isn't this a recurring theme in maternal health supplies that, you can talk about fragmentation for any of the products that we have to deal with. And here with tranexamic acid, we are looking at a product that reduces maternal deaths by a third. So there aren't many of these kind of medicines that can impact on survival as tranexamic acid does. And as we heard from Halima, this is a drug that's been around since 1962, at least invented in 1962. So we are looking at a good 60, almost 60 years of its existence. And we are still trying to generate interest. We are trying to reduce costs. And just on the quality issue, there are several SRA approved products, but one of the products that we have analyzed in Nigeria has clearly showed some quality problems and flaws. So I think it's a general theme occurring in maternal health supplies, and maybe the quality issues may not be as bad as oxytocin or misoprostol, but in all likelihood, there are some quality issues. There are clearly advocacy issues. We are working on several countries' national guidelines and EML updates. And what we are finding is it actually occurs in EML in several countries, but not with the postpartum hemorrhage indication. It clearly sits in another part of the facility. And so there is a little bit of fragmentation even there. So I think,
Metin,
thank you.
We have several questions.
I'm not seeing any of the questions.
You don't. I get to see them. You don't. I'm sorry. I will read them for you.
I have nothing.
Yeah, I can see them here. Peter Hall and Debbie Armbruster asked if, but I think we've already responded to this. But anyway, Peter and Debbie Armbruster would like to know if any manufacturers have submitted their dossiers to WHO PQ.
So I don't know if Mariana can answer that. I think we checked it a couple of months ago. There was none.
None.
But, I don't know if there is an update.
No, so far there were none. I confirm. Yeah.
Okay, and then it seems that Andrew responded to this, but are there any SRA products available to low and middle income countries?
Andrew?
Yes, there are. I can, if the questioner wants to reach out to me afterwards, I can send them a list of some of the ones we've identified as well. Yeah, there are multiple. I mean, Pfizer is, I think, we've identified as being the most dominant supplier in the market, especially in higher income countries, but also in low income too. Yeah, but the answer is yes, there are several SOA suppliers.
Okay. We have another question from Johan van Happeren. Is there any information on the composition pH of TXA injection for IM administration instead of IV administration, or is the formulation exactly the same? Maybe Halima?
Halima?
Yes, in fact, the formulation we're using in our study is the IV formulation. I know there's a company in France at the moment that's looking to see whether it can be concentrated down, because obviously if you're giving 1 gram, that's 2 5 ml injection. However, in our healthy volunteer trial, we gave 1 gram as 2 5 ml, and we've had, other than transient reaction, nothing, no other complications. And we plan to use the IV solution as the oral liquid as well. So, and we've already used the IV solution as the oral dosage, because if you can make just a vial available, then it will simplify the number of drugs you have to store. So this is partly why we're focusing, but the pH is, I think, in fact, in defending it, the oral use, it's the exact pH of saliva.
Okay, we have two questions from Alice Rosmini. I would like to ask first about evidence on adverse reaction for TXA, and two, is there any WHO guideline for TXA use for PPH specifically for humanitarian settings, or if it's going to be developed? So adverse reactions for TXA.
Yeah, I can take adverse reactions. We have data on the use of tranexamic acid in in trauma, in gastrointestinal bleed, in postpartum hemorrhage. We probably have data on over 60,000 patients. Half would have received tranexamic acid, and we have had no increase in side effects. The only time we saw side effects was in gastrointestinal hemorrhage, where a very high dose was used. We used 6 grams of tranexamic acid instead of the 1 to 2 grams that we used in trauma and postpartum hemorrhage. And also in gastrointestinal hemorrhage, it was used much, much later. So it's the only bleeding condition that we didn't see a survival benefit and saw an increase in seizures. But in postpartum hemorrhage and other acute hemorrhaging, we didn't see any increase in side effects.
Thank you, Halima. And this one is for Mariana. Is there any WHO guideline for TXA use for PPH specifically for humanitarian settings?
No, so far there is nothing.
There's nothing. Are there any plans for specifically for humanitarian settings?
So far not.
No. Okay.
But we can evaluate that, yes.
Then Peter Hall was saying, since there are no PQ products and there's nothing in the pipeline, are there funds to follow up, assist, persuade companies to submit their dossiers as we did in the QURHM program?
I suppose it depends how many donors are on the call.
No funds, Sam, specifically for this. Not that we know of. Okay, I don't have any more questions here. And we're just about to finish the hour. So Metin, you can take it from now.
Thank you, Milka. I think it just shows that, you know, even when we have the one of the best interventions in terms of life-saving capabilities, we are still struggling with many aspects of getting the evidence and implementing the drug at the needed location and place. And as Andrew articulated, you know, the sort of bottlenecks are multiple, and maybe for some we need implementation research, for some we need perhaps like Halima is looking at new product formulations, and we also need a concerted action on probably pricing, quality assurance, and it seems that nobody has actually looked into quality in terms of low and middle income countries. So I think there is clearly a lot of work to do in tranexamic acid, and also we need to remind ourselves that it's not a very easy to implement practice, especially in an emergency setting. So clinical protocols, clinical implementation guides have to be developed as well. So with that, I want to thank everyone for their participation.
I'm sorry to interrupt, but we have here a comment from Guido Rancelar. the medical expert group. He is saying that the medical expert group conducted a feasibility study to apply for WHO PQ on TXA, but had to conclude that there is no solid business case. How unfortunate it was given the very positive results just shown. And then he says the cost of PQ application versus the limited market potential given the limited numbers of countries that have adopted the TXA in the guidelines made it a non-viable solution. So this comes from Guido at MEG.
That's a shame, actually. But I would have thought that with so many indications for tranexamic acid and so many products in the market, there must be some business case that could be built around. So I'm not the expert. Andrew, you want to comment on this?
If you don't mind, I mean, I've not heard about this before, so it's all new, but there's clearly a big difference between actual current market and potential market. And it's certainly true to say that the existing market for TXA is, especially in sub-Saharan Africa, is very small. You know, it's not being procured, or it's hardly being used, and it is being just through the private sector. But that doesn't mean to say that the potential market isn't pretty great. You know, we were discussed here in the WHO recommendations guidelines are that TXA should be used in every case of PPH. And yes, there are constraints, limitations likely about where you would want to use TXA, and limits due to births probably occurring in hospitals, or at least women who can get to the hospital within 3 hours of giving birth, or perhaps the health centre as well. That still is potentially a very large market. And yes, funding is a concern. You made the analogy to magnesium sulfate earlier, but yet magnesium sulfate is an example of a commodity product which is procured by national governments. They're often stock out, it's true, but still is being procured. Now, I don't know what the price of a WHO pre-qualified version of TXA would be. I do understand that there are cost elements that come in once you have a pre-qualified product, a quality product. But I do dispute whether there's not an untapped market there that could be reached, and potential buyers from governments. What is missing is that catalytic funding, that support to actually get TXA rolled out in the country, get it introduced, get included in budget line items, get healthcare workers trained, and simply get momentum going. Produce that roadmap example that I was speaking about before, which other countries can then emulate and start using examples. So other ministries of health, other ministers of health can turn around and say, hey, our neighboring country is doing this, why aren't we doing this as well? That's what is missing. But the business case, the lack of a business case, yes, it's okay, I get it, it's not there today, but it's certainly, I think it is there. And I would suggest, Guido, that this is something we could talk about offline, but you know, I think this is worth looking into, and I suggest it could be worth investing in.
So for maternal health supplies, I think, and the TXA work stream, we are not going to drop this. We will continue, and hopefully, Milka, we will have other opportunities to bring and highlight the use of TXA, both in terms of evidence generation, standards, quality, implementation, pricing, procurement, and all the issues that relate to that. So I'm going to say thank you. And Milka, do we have any last comments from you?
Nothing else. And we're having our maternal health supplies caucus meeting on December 15th. You have received a save the date, so we'll talk then. Thank you very much to our presenters today and to Metin for this wonderful webinar. Have a great day.
Thank you. Thank you. Bye-bye.
Bye. Thank you.